A differential case presentation by Emily C. Gomes. The scenario is as follows. A 28-year-old woman with an opioid use disorder with a history of heroin use. The patient has a history of PTSD, but no other medical problems or medications. She is currently single and lives with several roommates. She also has a history of legal problems with some jail time. She endorses sexual activity with men and women, but with an inconsistent use of protection. The patient presents with shortness of breath, chest pain, flank pain, and fever. The demographics of patients with pulmonary complications of IV drug abuse or infective complaints, such as pneumonia, infective endocarditis, and pulmonary embolism, skew to younger white individuals, although males are represented in higher numbers in these statistics than females. This does not exclude the patient from this demographic. This grouping of symptoms is classically indicative of a pulmonary complaint, particularly when paired with the history of heroin use. The differential diagnosis is as follows. Pneumonia, which is the most common disease with a patient having an IV drug use history. This disease also fits all the presenting symptoms. Second is infective endocarditis. Fits the symptom presentation, though flank pain is less likely. It is also a known disease linked to IV drug abuse. The rates of infective endocarditis doubled from the year 2000 to the year 2013. Third, pulmonary embolism. Fevers are less likely in PE, though can occur in a presentation with septic PE in the setting of IV drug abuse, but still are rare. The diagnosis comparison remains the same from week 7 to week 10. Pneumonia, endocarditis, and pulmonary embolus in that order. The differential diagnosis, though it remains the same, does have additional diagnostic features that are more specific to the scenario in this week 10 differential diagnosis comparison. In a young, otherwise healthy female with a history of IV drug abuse and symptoms such as she presents with, brings these specific diagnoses to mind. No change in differential diagnosis is indicated in this case. Pneumonia fits the presentation most thoroughly, as well as being a more common complaint with each subsequent diagnosis, less common than the first. In pneumonia, inflammation of the lung parenchyma occurs from a viral or a bacterial causative agent, though with IV drug abuse, bacterial is more common. This infection can occur through aspiration due to the lessened cough reflex and respiratory reflex with heroin use, or can occur traveling along the mucosa into the lower respiratory system. Congestion occurs with the inflammatory process related to the permeability, increasing permeability of the blood vessels in the lung tissue, and also vascular congestion within the alveolar wall with pooling exudate inside the alveoli. The exudate then solidifies into a consolidation, most usually in one lobe of the lung. This exudate consolidation is made up of neutrophils, red blood cells, and fibrin. The pleura can become inflamed, particularly when an entire lobe is affected. This causes pleuritic chest pain, and infection can spread to the pleural cavity, known as empyema. Exudate and consolidation decrease diffusion of gas across the alveolar membrane. This membrane is specifically designed to allow for easy exchange of gases, such as CO2 and O2. This decrease in diffusion due to the exudate and fluid buildup leads to hypoxia and acidosis, both of which worsen with the increased metabolic demand from the infectious process. Streptococcus pneumoniae or Staphylococcus aureus are the most common causative agents in a patient with community-acquired pneumonia, particularly in a IV drug abuse setting. Infective endocarditis is second. Staphylococcus aureus is the most common causative agent in infective endocarditis, with more than half presenting with this agent. The causative microorganism obtains entrance through an infected needle stick in a history of IV drug abuse. And this causative microorganism attaches to the endocardium, causing inflammation and formation of vegetation on the cusps of the valve. The formation of vegetation on the heart valve, most commonly the tricuspid valve in infective endocarditis, creates a mass that damages the valve tissue. This vegetation is made up of fibrin, neutrophils, and platelets. Microbial growth further activates the coagulation pathway, leading to an enlarging mass and also creating a medium for increased bacterial growth within the fibrin scaffolding that is difficult to eradicate by the immune system. Septic pulmonary embolism can originate from peripheral injection sites with thrombophlebitis from dirty needles or from infective endocarditis with pieces of the vegetation or mass breaking off and circulating. The blood clot or mass obstructs the blood flow through the lung tissue from the pulmonary artery or branches of the pulmonary artery. This can also cause reflex vasoconstriction, which can occur and worsen resistance due to the blockage of blood flow. The symptoms of a septic PE depend on the size and nature of the PE. Fever occurs less commonly with PE, but can be seen in up to 10% of patients with IV drug abuse history presenting with pulmonary embolus as a septic PE. The patient presents with fever and positive blood cultures, shortness of breath, and chest pain. Pneumonia is the most likely causative agent in this setting. For diagnosis and treatment, the following is included. IV drug abusers have a 10-fold increased risk of community-acquired pneumonia compared to the general population. Pneumonia fits all the presenting symptoms, with pleuritic chest pain that can be referred to the sides or back, shortness of breath due to the pooling of exudate and fluids in the lungs, and fever from the infectious process inflammatory response. Chest X-ray is indicated in diagnosing pneumonia. On chest X-ray, the radiographic imaging can be indicative of what type of causative agent, with a lobar pneumonia being more likely to be caused by a bacterial agent. Sputum culture is also obtained to ascertain the causative agent. Blood cultures are done as well if indicated, with worsening symptoms, elevated temp, or not responding to initial treatment. They are also more likely to be obtained in the setting of a patient with IV drug abuse history. A CBC with differential, CMP, SED rate, CRP are also indicated. HIV testing should also be performed in the setting of a patient who endorses IV heroin use with its attendant risk factors, as well as a history of sexual activity with inconsistent use of protection with men and women. An oxygen level is obtained, and hospital admission is dependent upon the severity of the symptoms, though there is a low threshold for admission with a patient with these risk factors. A referral to infectious disease would be indicated if cultures reveal a drug-resistant strain or if the patient is HIV positive. Individuals with an IV drug abuse history often present at later stages of the course of a disease and frequently present to the ER for management. This delay complicates their treatment options. Initial treatment would be empiric and directed to the most common community-acquired pathogens based on the X-ray picture of focal or diffuse opacities. But if culture and sensitivity shows a specific pathogen, the antibiotic prescribed would match that information. Most commonly, a beta-lactam plus a macrolide would be indicated, or vancomycin if the patient is thought to have risks for MRSA. The course of treatment would include IV hydration for support, IV antibiotics, oxygen and nebulizer therapy if indicated by POX and respiratory sounds, and antipyretics would be indicated in a patient hospitalized for community-acquired pneumonia, particularly with an IV drug abuse history.